Our topic continues with secondary hypertension. Here, however, we're in the concept, or we're in the topic of endocrine. What does that mean? Well, remember, hypertension crosses all borders. At this point, we've completed secondary hypertension when dealing with the renals, right? And we went through those important differentials. Here, under endocrinology, when we refer to Cushing's syndrome, now right off the bat, close your eyes and think about all the different sources in which Cushing's could take place. As soon as you hear about Cushing, take the C in Cushing, please. And you know that you have excess cortisol, right? Excess cortisol, whatever form that may be, glucocorticoids, prednisone, what have you. So here we have Cushing's syndrome. What are the 4 different causes? And as you go through them, tell me as to what is the most important or what is the most common cause of Cushing. It's actually not even from our body. It's exogenous sources. What's that called, please? It's called factitious. It's called iatrogenic. It's exogenous. Do you understand? Any time that you see those 3 words, what are they again? Iatrogenic, exogenous, or factitious. That too should mean that that particular drug, hormone, whatever it may be, is coming from an outside source. Is that clear? I hope so. So that's the most common, isn't it? Think about prednisone and all the different reasons as to why a patient might be taking prednisone. But is that going to give you secondary hypertension? Well, let's move into this. This is Cushing's syndrome. Where am I? Not the anterior pituitary. How do you know? If it was anterior pituitary, would you call this Cushing's syndrome? Good. No, you wouldn't. You'd call this Cushing's disease if it was anterior pituitary. So, Dr. Archer, what in the heck are you getting at? If you had a tumor in the adrenal cortex that is producing cortisol, are you only producing cortisol? No. You might also be producing aldosterone. Now you're getting to my point. What's my topic? Secondary hypertension. Remember, please, in this case, the pathology, the end game is the fact that you're going to develop increased blood pressure. And that increased blood pressure is coming from aldosterone in Cushing's syndrome. Take a look at the patient here. The face, moon faces. What are we looking at in this patient's torso? It's the fact that there's trunk obesity and we have striae. What else might you find on the back of the neck, perhaps? You're looking at buffalo hump, right? So that's your patient in general with Cushing because of excess glucocorticoid from whatever source. Just to be complete, the other sources included your anterior pituitary and then also your lung, right? And from the lung, you should be thinking about, most commonly, small cell lung cancer. Good. Now, my point is this. If you produce too much aldosterone, at some point in time, what may happen? You may then cause increase in blood pressure, resulting in secondary hypertension. Cushing. Now, be very careful, because our next differential here for secondary hypertension, take a look. We have removed our patient, because this is Conn syndrome. Conn syndrome was not going to have moon faces, buffalo hump, and so on and so forth, as we just saw. Conn syndrome is a primary, listen to what I'm saying, it's all about verbiage. It's all about terminology. And if you're not careful about terminology, when you're reading something, it's quite easy for you to miss a question. It might be quite easy for you to misinterpret your patient. You don't want to do that. So, it's a primary hyperaldosteronism. Now, this would mean, what's primary mean to you? It means that that particular problem or pathology is actually taking place from that organ. Aldosterone comes from there. From where? Adrenal cortex. What layer? Glomerulosa. The most superficial layer. You have a tumor there that's producing too much aldosterone, right? This is called Conn syndrome. This is primary hypoaldosteronism causing what kind of hypertension? If you said primary, I'm sorry. As much as you want to, please note this is not primary. It's secondary hypertension. How common is this? More common than one would think. Make sure you know about Conn's. So in Conn syndrome, it's a primary hypoaldosteronism with a tumor in your adrenal cortex producing too much aldosterone, resulting in what kind of hypertension? Secondary hypertension. Is that clear? Now give me the labs here, because you're not done. You're going to be given a sheet of labs, and you have to be able to interpret as to your patient having Conn's. What happens to sodium? Increase. What does that mean? Greater than 145. Good. What about potassium? You're getting rid of it because you have too much aldosterone. So my potassium is less than 3.5. Good. And then what about hydrogen? You're getting rid of your hydrogen. So what happens to your pH? Increases. Welcome to alkalosis. Is that clear? Welcome to Conn's. This is something we have looked at, we will look at, and will forever look at because it comes up so many different times. Let's continue. Endocrinology, now we have pheochromocytoma. Where am I? Where are you? You're still in adrenals, but what part, please? The medulla. In the medulla, you might have a tumor. You have a tumor that does what? Produces too much of your epinephrine. Remember, normally speaking, 80% of your epinephrine comes from where? It comes from the adrenal medulla, doesn't it? 80% does. What about epinephrine? Epinephrine works on many receptors, catecholamine receptors, alpha 1, alpha 2, beta 1, beta 2. At low doses, works on what? Good, beta. At higher doses, works on alpha, works more like norepinephrine. You know that from pharm. I'll walk through that quickly. Right now, let's just focus upon the path, please. In pheochromocytoma, you have too much epinephrine. And do you have this epinephrine all the time? Is it a constitutive? No. It's episodic. You pay attention to the term episodic hypertension. If you have too much epinephrine at some point in time, might you find its metabolites in the urine? Sure you will. What's that called? VMA. Vanilmendic acid, maybe metanephrine, so on and so forth. This episodic hypertension, headaches, diaphoresis, what's that mean? Remember, too much sympathetic activity. Would you please tell me how you sweat? Is it sympathetic or parasympathetic influence? Sympathetic. Good. Remember one of the big exceptions. Sympathetic muscarinic receptor, diaphoresis. Palpitations. Boom, 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 boom. All of the time? No. Not like Graves' disease. Is that clear? Give yourself a differential. Palpitation, Graves. Here we have pheochroma. Let's continue. Adrenal mass. Where are you? Adrenal medulla. What kind of tumor? It is a benign tumor. What are you going to find? Plasma-free metanephrines, urine, there it is, VMA, vanilmendic acid. What does that mean? It means that these are the metabolites of your epinephrine being broken down. Rule of tens, this is something that we discuss in endocrinology. 10% of the time, it might be sporadic. 10% of the time might be familial. 10% of the time might be adrenals that are affected, so on and so forth. What else may result in secondary hypertension when dealing with endocrinology? How about the thyroid gland? If it's hyperthyroidism, it might then increase your systolic blood pressure, SBP. And if it's hypothyroidism, then it might be something like increased diastolic blood pressure. And that's important for you to know clinically, please. Hyper is the fact that your patient's heart feels how? Oh, it's palpitating. And you have hypothyroidism, increased diastolic blood pressure. Thyroid gland. Let's continue. What about another endocrine pathology that may result in secondary hypertension, but this is hyperparathyroidism? What is this? This is the fact that you're producing too much, what? PTH. Where? Your parathyroids. Where am I? Right around the thyroids, right? Your thyroid. And you have your parathyroid producing too much PTH. What is that going to do? It's going to run to the kidney. It's going to do what? It's going to reabsorb the calcium. What kind of effect does calcium have on your blood vessels, please? Think about that. Your blood vessel normally is what kind of muscle? Smooth muscle. What's smooth muscle mean to you? Think about alpha 1. Are you there? Alpha 1. Bring in some biochem here. You have alpha 1 receptors. What does it do? It stimulates your, good, phospholipase C. What are you going to release? IP3-DAG. What are you going to do next? Release calcium. Aha. What does alpha 1 do to your blood vessel? You know it causes vasoconstriction. So therefore, you have the calcium bind to clamodulin so that you do what? Vasoconstriction. What is that going to do to your TPR? And here we'll go ahead and call this PVR. It increases resistance. Peripheral vascular resistance is going to be increased. Is that going to increase your blood pressure? Sure it will. What kind? Secondary. Are you following me? Everything that we're going to do here is have an explanation, has a story. You relate this to a patient, a presentation, or whatnot, you're in good shape. You cannot be fooled. I don't care who you are. You understand your patient. You won't miss a single question, period. Next. Under cardiovascular, still secondary hypertension, we have a condition called coarctation of aorta. As soon as you hear coarctation of aorta, close your eyes, think of what, please? Think about this patient. Listen to what I'm saying. There's webbing of the neck. There might be two cusps of the aortic valve. Interesting. If it's a female, well, XO, right? And if it's the ovaries, may result in something called dysgerminoma, called streak ovaries. Who's my patient? Turner syndrome. In this patient, you also notice that the blood pressure in the carotids might be higher than the blood pressure in the extremities. By extremities, I mean down by the feet. Think about the dorsalis pedis. The blood pressure in your upper extremity might be higher than the blood pressure in your lower extremity. How did that occur in Turner? Remember, Turner is a genetic problem with XO being the chromosome. Next, what happened? I told you that there was webbing of the neck. What's that called? It's called lymphangioma, isn't it? It's the fact that the lymph is becoming dilated. And you might actually be able to see this in vitro with the ultrasound, in which the back of the neck, you see it being filled with fluid, right? That's your webbing of the neck, quote unquote. Make sure that you know the full understanding of webbing. Number 2, what else did I say? I said that the aortic valve, which normally has how many cusps? It has 3 cusps, normally. But is it possible that a patient might have congenital bicuspid aortic valve? Sure they can. Who's your patient? Turner. And then what about the blood pressure? The differential, coarctation. What's that going to do? I want you to go back to physio, and I want you to think about a pipe and a tube. And you're going to add a resistor right in the middle. You see that right there? You added a resistor in the middle. When you added a resistor in the middle, what then happened to the pressure proximally? It increased. What happened to the pressure distally? It decreased. What did you do? You added a resistor in a series. Where am I? The aorta. And you coarcted. What's coarcted mean? It means constriction. So what happens to the blood pressure in the upper extremity? Voila! You've increased it. See how simple it is? And what about the blood pressure in the lower extremity? It's decreased. What do you think happens to perfusion of a kidney? It decreased. What kind of questions might they ask you on physio? They might ask you about decreased perfusion of the kidney and coarctation. True or false? True. So therefore, what are you going to release? Renin. Good. And you go through the same concept. Secondary hypertension, coarctation. Let's continue. Obstructive sleep apnea. Now for this, I want you to think of maybe an older patient, an obese patient perhaps. And it's the fact that there might be obstruction taking place while breathing out. And so therefore around the vocal cords, maybe there's the pharyngeal folds and such, and there might be excess muscle. There might be excess flap, quote unquote. And so therefore it makes it difficult for your patient to properly breathe, especially at night. Sleep apnea. Maybe for intervals of greater than 10 seconds, there might be lack of proper breathing. That's amazing. That's very scary, isn't it? At some point in time, what is going to happen? This patient is not breathing properly. So if there isn't proper ventilation taking place, then what is the patient retaining? Because the patient is not able to blow off. What are you supposed to blow off normally? Good. Carbon dioxide. But that isn't happening in a patient with obstructive sleep apnea. You're literally obstructing the ability to exhale your carbon dioxide. Where is it remaining? Within your blood. What does carbon dioxide mean to you in terms of pH? Carbon dioxide equals acid, doesn't it? Of course it does. Think about the carbonic anhydrase formula. So you're producing acid. So what kind of acidosis is this? Respiratory acidosis, isn't it? And at some point in time, maybe with obstructive sleep apnea during the day, you might find it a little sleepy. And the patient might be feeling a little tired and such. So obstructive sleep apnea. So now what happens? Obesity, rapid weight gain with snoring, neck size greater than 17.5 centimeters. What kind of treatment measures are you worried about in this patient? Well, you need to make sure that you clear up that airway ASAP. Think of CPAP, continuous positive airway pressure. What kind of drugs might you be thinking about treating this patient with obstructive sleep apnea? OCPs, NSAIDs, steroids, phenylephrine. Okay, so think about this. This is no joke. Obstructive sleep apnea, once again, is a huge issue. And so therefore, those of you that are going into family medicine and so on and so forth, you're going to be involved in sleep studies. And that is going to be a huge part of your practice, because you're going to find a lot of people coming in with such issues and would have secondary hypertension. Keep that in mind.